From between 24 weeks and 33 or 34 weeks should be offered corticosteroids. We are very open to giving corticosteroids, and we should give it at least till they say to give it up to 36 weeks. And a combination of clinical assessment, maternal blood test, CRP, and total cell count, and these should be used liberally to use to diagnose chorioamnionitis, because we don't want to end up with this dreaded complication. And finally, of course, women whose pregnancy is complicated by PPROM after 24 weeks and who have no contraindications to continuing the pregnancy should be offered expectant management. Timing of the birth should be discussed with each woman on an individual basis with careful consideration of patient preference and ongoing clinical assessment. In women who have PPROM, are in established labor or having planned preterm birth within 24 hours, intravenous magnesium sulfate should be offered, and we are liberally offering it now in most of our patients. So coming to really points to remember, it complicates up to 3% of pregnancies and is associated with 30 to 40% of preterm births. So we have to be extremely careful on this point. It can result in significant neonatal morbidity and mortality, primarily from prematurity, sepsis, which is a big problem in our country, cord prolapse, and pulmonary hypoplasia. In addition, there are, of course, as I mentioned, risk of chorioamnionitis and placental abruption. The median latency after PPROM is usually 7 days and tends to shorten as the gestational age is advanced. And not unlike what I mentioned, it is actually less than we are having problems with chorioamnionitis. Well, one thing we have to know that it is a major public health problem. We cannot afford to have babies being born with cerebral palsy because the health costs are enormous, and more than the health costs, you have to understand what the parents go through. They have to deal with this child for the rest of their lives. So we have to be extremely careful. It directly contributes to 75% of neonatal mortality and 50% of long-term neurological impairment. So this is a huge problem, and it accounts for 35% and 10% of healthcare spending for infants and children, respectively. So if we are going to be careful, we have to not only diagnose issues here and then move forward. But the biggest problem is that the incidence of preterm labor has changed very little in the last 40 years because of uncertainties which continue to be there, and we can use the best strategies, but we are actually failing in that. So the prevention and effective management, along with improved neonatal outcome, will only occur if we are very focused on this. We think about it. We anticipate the issues. Infection is its greatest risk factor. Women who have delivered with having a PPROM or PROM in the past, we have to be careful and watch them that they should not land up with another similar issue, which actually all these will have a profound impact on the societal and long-term health costs. So if I have to say about a take-home message, like our teacher, Professor Padma Rao, used to always say, it is identify the potential risk factors for PPROM and avoid co-amoxiclav. And more importantly, we all must, do fetal neuroprotection with magnesium sulfate. There are very important saying by, Confucius: I hear and forget, I see and I remember, I do and I understand. So all of us must do enough for fetal protection in PPROM. Thank you very much for your patient hearing. I'm sorry for that interruption, but I'm open to questions. Whatever little I know, I will try and answer. Thank you very much for the opportunity.
No, it's actually a very good talk, sir. And as changing lifestyles and everything, most of the girls are actually falling in this category of this risk factor for the preterm PROM. And this age group, this gestational age of 25 to 31 is very tricky for counseling also and for treatment also. What to counsel and what sort of treatment we should give. And after that, if the treatment fails, still we have to counsel the patient again and again that we failed even after giving everything. And actually the question is very from Namita Agarwal. How is your experience with medicine like amniosil to seal minor leaks? Because this particular medicine, it is promoted just like this is just a Amar Booty of the preterm PROM. Each and every time the pharma person comes and he says Amniosil de dijiye, everything will be okay. So
I'm
what?
glad that Namita asked me this question, because the person who can give you more knowledge about this is Dr. Sarita Bhalerao. Sarita is
Yeah.
there? Yeah, Sarita?
Sarita madam is there. Sarita ma'am?
No, she.
No, she's-
Actually, she's not there. Yeah.
Okay. So I don't have much experience with this. So if anybody does, please speak up. I'm very
Dr.
frank in
Jyotsna, are you
saying
there?
what I know and what I don't know.
Actually, I am using this product a lot of means, but this is a just feeling just this is a very high amount of everything.
So
Aminos,
is it a feel-good phenomena, or is it does it actually work?
just like placebo, sir.
Sir, if I may be allowed to say something,
Yes,
these
yes, ma'am.
amino acids and all these, basically they are only time pass.
Yes,
We all know that FGR means that there is some pathology for the reason of which the baby will not pick up the weight and all that. And it has to be monitored by Dopplers. We have to distinguish between early FGR, late FGR, and preterms. And we have to go with the management. Another thing that I wanted to mention is the role of corticosteroids. So presently we are only giving up to 34 weeks. Beyond that, we are not giving antenatal corticosteroids because the premise is that on long term, there is more problems with the babies, children having attention deficit syndrome. And so it's like this, that up to 34 weeks, antenatal corticosteroids need to be given. And beyond that, what is your take on it? Because we have stopped giving.
Yeah, see, I also give it up to 34 weeks.
Yeah.
But then what happens, I'll tell you, if this problem occurs at 35 weeks, the first thing the pediatricians come and ask you, have you given the steroids?
No, sir, I wanted to clarify
That's
because
what I'm telling you.
we
So
changed our practice because we had a webinar and there the pediatrician told us. We were informed by the pediatricians that the pediatricians have actually, this is their study, that what is the harm of
this study
giving
came out a few
antenatal
years
steroids.
ago. This study came out a few years ago about this attention deficit disorder. And it led to a little bit of thing, but then ultimately, I don't know what happened to it. But if you have heard it from a pediatrician, I'm very happy. Because
I can even quote the pediatrician. He's a very reputed.
No, you don't have to quote names.
neurologist,
I mean, I believe that's it.
Yeah. And this was a very important point. And then when we reviewed also, there is a lot of controversy. In fact, those who are giving and they are not informed that you should not be given. It is having, at age
I don't
5
think there's
and
any
all.
study, Mitra, which says you should not give corticosteroids. I have not come across. Maybe if you have, please share it with me.
I will definitely.
And I'll update my presentation.
up to 34 weeks it is good, but
Yeah, up to 34 weeks, definite. There's no.
and this type of-
100%. Beyond that,
Yeah.
actually we have to give only the antibiotics,
Study,
methyl, and
Cochrane, sorry.
no, sir, yes, sir.
No,
Sorry.
I said Cochrane is very clear on that.
Hmm.
If it's term, you don't, close to term, you don't give it. Even for corticosteroids, leave alone magnesium sulfate.
Yes. So the answer for Namita Agrawal is actually there is no study from our side for amniosin. And the second question is, should we give Maxelf to every preterm up to 34 weeks, whether we deliver it or not?
I would support that actually, Dr. Jyoti. I would support that. Both the role of Maxelf and steroid. Now, we just had a brilliant discussion with Dr. Krishnandu and Dr. Mitra regarding the role of steroids. I think there is definitely a role of steroids even at 35, 36 weeks. Now, saying something about the article about the attention deficit disorder in children, I think that diagnosis itself is a bit overrated among the pediatrician. I mean, you take any child, for our children, we also had children. The children, I mean, doing mischief, doing masti, doing playing, and they label it as attention deficit disorder. And the parents are proud that my child has been labeled as an attention deficit disorder. I think this is a big humbug. I mean, I would oppose the pediatrician labeling a child as attention deficit disorder. I would counter question my pediatrician. What do you mean by attention deficit disorder? The child is growing normally. The child is playing normally. The child is standing first in his class. And just because he is playing or just because he is doing some mischief, I would not label that child as attention deficit disorder. So I will not really agree with the relation of steroids and attention deficit disorder. And I would definitely give steroids even at 36 weeks, because that has really given lots and lots of help in my personal practice, along with myself. And of course, there are many studies, both Cochrane review, Dr. Gupta will agree with me, Cochrane review and all the different studies in Indian textbooks also have recommended the beneficial role of the steroids. So yes, I would give steroids. Attention deficit is not the diagnosis for me.
Also, the question is about the Maxelf. If we are going to deliver the child, whether we should give it, and
We should.
Yes.
We should. Whatever little benefit it has, we should give. Yes.
Okay.
Even 24 hours we get, we should.
No, but what I did not understand from the question is whether we deliver or not means what?
No, we deliver, sir. Sir, we deliver, that will depend on the obstetric indication and the neonatal indication.
I'm not
I
questioning
think
you.
what
I'm
Dr.
asking the
Yasmin
question.
means is,
That once, even if we are deciding at 34 weeks that suppose the things settle, everything is under control, it's always safe to give magnesium sulfate.
No, sir. If it is PPROM, confirmed PPROM with litmus test and everything, we give Maxelf and we deliver. At 34 weeks, there is no role of conservation in PPROM.
No, that's what I'm trying to tell you is this question is that whether you decide to deliver or not, we are always going to deliver. That's what my question is.
delivery. Actually, we
I-
decide after 34, after giving all the treatment, we have to decide for the
Yeah,
delivery.
because we don't want the mother to get
Yeah, we do.
chorioamnitis or other problems.
We definitely should go ahead and deliver. As the level of NICU care has definitely increased even in level 2, tier 2 and tier 3 cities in India. So we have a very good NICU care. Now leave aside Bombay and Thane and Calcutta, which are the premier cities, but otherwise everywhere the NICUs are good. So I think we should definitely go ahead and deliver to prevent the other complications of PPROM.
we should let Yasmin
That
tell us what the confusion is all about. I think her question is not very clear and she is raising her hands so that she
See,
can
my
ask the question
concern is if she is 29 weeks now, her AFI is only 3. Means a single pocket is more than 2 centimeters. We are going to continue her pregnancy because her Doppler studies are normal, her counts are normal, her C-reactive protein is within normal limit. So if I'm going to continue, even if there is minimal leak, should I give her Maxelf or not?
yes, my answer will be
You
yes.
should,
because
yes,
you don't
even-
know how
yeah.
things will change.
Yes,
Because
totally
things are
agreed.
very, it's, you can't say that you should take every precaution. There is no harm in giving Maxelf.
Yes, absolutely agree.
You gain by giving Maxelf. You don't lose anything.
Sir, any few, few words or any experiences regarding amnio infusion at this stage, or for this case particular?
Yeah, that frankly speaking, I think the feto-maternal people will answer that, and there have been places, but then if the leak is not shut, amnio infusion, how long will it help? I don't know.
Even sir, 1-2 days or even 1 week is extended. That's beneficial. That's what Dr. Patil, yeah, I agree. 1 week is a long time.
Too much you're talking.
But sir, Dr. Patil from Kolhapur, he has very good results. He has managed to conserve up to 1 week also.
I'm sure. I'm not.
So it's all trial and error.
and it's
sir,
all
you will agree,
the
all trial and
setup
error.
where you're practicing.
Yes, all setup is where you're practicing. Totally agreed.
I think this is a very good talk and a lot of discussions on it. Dr. Krishnandu, you've done a wonderful job. I must congratulate you sharing the index journals and the green top guidelines. Most of our postgraduates who are here, I'm sure they've taken a pick and will follow what you have done. I think, Jyoti, if we agree, we can go to Dr.
I'll be more than happy to share the PDF format of my slide to Parag, and Parag can put it up in the ICOG group. I have no problems.
That is very good. That's
This is
very
my
good.
collated data.
Very
It's not
nice.
my data.
Every talk with the green top guidelines, sir, we have to quote to the patient, and even in the court of law, we can actually quote these things that we followed such protocol. We can't do the layman type of things. If we are following the protocol by RCOG or green top or everything, then we are also safe in this particular preterm prom, not the prom after 33. But this preterm prom is actually a very bad situation for any obstetrician. Thank you very much, sir, for your
Thank
So
you
your
very much for
lecture
the
anyway will
opportunity.
be put up on the ICOG website. So all the viewers who have missed it can definitely watch it again.
Okay, lovely.
Thank you so
Parag,
much
and
for your
we have
presentation.
the recording of this also. We could have the recording of this session also, Parag.
Yes, it will be put up on the ICOG website soon.
Excellent. That's nice. So I think we can go next to our excellent speaker, renowned endoscopic surgeon, Dr. Korean. I think Dr. Madhuri Chandra, would you like to introduce him?
Oh, sure. Pleased to introduce Dr. Korean Joseph, who's from Chennai, formerly Madras. Okay, he's done his endoscopy training from Mumbai and Hamburg. He's trained in YAG laser surgery. He's been the ICOG president from October 13 to June 15. He's on the FIGO board. He's also the member of ISCG board member. He was the vice president of FOXI in 2008 and the organizing chairperson of All India Congress of Obstetrics and Gynae 2015 Chennai. I think we all enjoyed that, where there were over 10,000 delegates is what he's put up. He's been the past president of the Obstetrics and Gynae Society of Southern India. He's got an FRCOG, honorary FRCOG in 2023. I think over to Dr. Korean Joseph without wasting any more time, because we should hear what he's going to say.
Hi, good evening. Can you hear me?
Yes, we can.
Okay,
Yes,
good.
we can hear you.
Thanks.
Yasmin, can you put your hand down?
Yeah. Okay, good evening, everybody, and thanks. I bring you greetings from Chennai. We refer to it as the Mecca of health. A simple statement, I'm no professor like Professor Krishnendu Gupta. I'm a simple practicing OBGYN. So I like always to say that life is like a hot bathtub. The longer you stay in it, the more wrinkled you get. I think I've stayed in it quite long, and I'm pretty wrinkled all over. So what you're going to hear is now a lot of my wrinkles coming out, and I do hope it makes practical sense to all you people. I just want to invite you to a small international conference we are having at Chennai. This is with the whole of Southeast Asia, from Taiwan, Hong Kong, Japan, speakers from all over the place. And especially for postgraduates, we have a bargain rate of just 7,500 for all the 3 days. Imagine if you can present a paper here, it becomes an international paper. So please take the chance, register. All the details are on the website. You can find, if not, contact me. My topic today is management of fibroids in pregnancy. It's a rather tricky topic in that there is very little things to do except sit and watch. And maybe if your watching is not working out, do some treatment. That's all my whole, in a nutshell, what I'm going to do. So basically the diagnostic dilemma of myomas. When we were young, we had women coming with large myomas and early pregnancies, and people saying, terminate the pregnancy, and stories like that. And when we treat, how to anticipate the problem is the next question which I was wanting, which we'll try and go into. Finally, a little bit about should fibroids be operated and the follow-up. A simple slide on myomas, which I always like to share, is that a myoma arises individually by mutation from a single smooth muscle cell. That means each myoma in a uterus has got its own identity, and they require estrogen for growth. Now, myomas are made up of varying proportions of cells and matrix, that is the living and the dead. And if one is found, you have 80% chance of additional myomas. And recurrence, that's related to surgery. But the simple question all the patients keep asking you is, why did the myoma come? And the answer which I got from a Sudanese professor is that the uterus must grow something. So either you have about half a dozen babies or you keep getting myomas. I think it sounds pretty crazy, but that's the important message. So what does fibroids or myomas do to pregnancy? This was from an IVF, from human reproduction. which says that surprisingly, fibroids decrease the live birth rate. That's related to IVF. Fibroids in women below 37 years make a 25% reduction in live birth rate. In IVF, also less. So the message I wanted to ask everybody was, do fibroids do anything to affect a pregnancy and thereby a live birth rate? So let's go on to these fibroid stories here. What happens to a fibroid during pregnancy? Just a sec, let me just. Yeah. Now, a fibroid in pregnancy occurs around 0.6 to 10%. It varies with age and race. The younger the patient is, the incidence is less, but the older the patient is, the incidence is more. But then what happens? We are all worried about its growth. A very interesting study from Mitro in Fertility and Sterility 2022 tells us that if the myoma is less than 1 centimeter, it may grow around 2 to 4% per week. So it may get bigger and bigger, may get to 5, 6 centimeters. Don't panic. But if the myoma is 1 to 3 centimeters, there's no or even minimal change in the myoma with time. And if the myoma is larger than 3 centimeters to very large myomas, overall, during the course of the pregnancy, it would decrease in size. There are small factors which affect the growth, like age, race, ethnicity, a lot of other factors like that. I'm not going into that. So the simple answer to this question is, stop worrying. If a patient comes with a myoma and pregnancy, leave the myoma alone. Don't panic. Don't tell her to go into any stories. What about postpartum? 90% decrease in size, but 10% increase. Now, some of the myomas decrease, but some may increase due to degeneration, may become cystic, and may become worrisome. So that's the worry about growth, and we're really not going to worry about that. What about symptoms? In 11% of the patients, a patient would come to you with severe pain in the first or the second trimester of pregnancy. Pain may be mild, maybe occasionally severe with leukocytosis, fever, nausea. All of us know red degeneration, and keep running around without knowing what red degeneration is. Basically, it is just a leukocytosis. There may be a certain amount of ischemia into the myoma, causing the pain and the discomfort. The myoma size also may increase, and this may occur in larger myomas. Occasionally, you have a little bit of vaginal bleeding. It may come from a polypoidal myoma, which is in the cavity. It may come from near the cervical region. Again, really nothing much to worry. Fever associated with red degeneration is rarely erythropoietin mediated. What would be the signs? Signs are just acute tenderness with fever, vomiting. It may sort of mimic an acute bowel incident. So these are the only things with myomas we have to worry. But remember, when I said pain, it's just in 11%. The remaining 89% of them go without any problem at all. So don't panic at the first sign of stress. So what are the problems which may occur, and what are we worried about? Problems, very simple. I said about degeneration. If it is a pedunculated myoma, it may undergo torsion. Pregnancy loss is there, especially in the early first or second trimester. Now, why does this occur? It may occur because the myoma is behind the placenta. It may impede the blood supply. Sometimes the myoma is so large that the pregnancy does not grow properly. You can have a pregnancy loss. Sometimes the myoma bleeds a little bit, and that may also disturb the pregnancy. The next entity, preterm labor, Dr. Krishnendu gave us such a lovely talk on. I was very impressed. And in fact, I was getting quite worried how I'm going to talk after an erudite speaker like Dr. Krishnendu. Preterm labor, again, can occur because of the space occupied by the myoma, by the location of the myoma, sometimes by the number of myomas. Again, this is a problem which one has to anticipate when you're dealing with myoma. If the placenta is attached to the myoma, the possibility of separation, premature separation is there. And that's why you have an incidence of placental abruption. I haven't purposely written all the percentages because the percentages in all these vary on the patient, on the myoma, on the location of the myoma, and thereby all the studies, I could give you any rate between, say, maybe 2% to maybe 10% to 15%, and it's not going to make much sense to you. The other problems we have to be worried are placenta previa. Now, why would the placenta go and get implanted low down? Implantation low down, again, may be caused by a large myoma occupying the upper part of the uterus. It could also be caused by the fibroid denying enough blood to the placenta. I mean, the blood supply to the placenta, and thereby the placenta sort of spreads itself more to keep itself, get itself more blood, and you have a placenta previa. The other possibility is a malpresentation. We have seen this very often. We have had situations where the entire lower segment is occupied by myomas and the baby is above the umbilicus. So malpresentation can be there, but these are usually with myomas which are larger than 5 centimeters and myomas which are in the lower segment of the uterus. The next problem is abnormal labor, or what we would call as dysfunctional labor. Here the myoma impedes the normal uterine contraction. And the minute that comes, the patient does not progress well in labor, and we find our sort of induction of labor and progress of labor is held up because of this. So all this results in cesarean section very often to take the baby out. And in cesarean section, again, we have issues at accessing the baby, and I'll come to that a little later. Finally, the problem which used to really worry us before was PPH. Because you have a large myoma inside, after the baby is born, the uterus very often does not contract. And remember, the contraction of the uterus or the myometrial contraction is what decreases or stops the bleeding after delivery. So PPH one has to be worried about. We have to anticipate and be ready with blood and with the uterotonic agents to decrease PPH. Another very interesting factor which has come out with these myomas in pregnancies is, remember that myomas today can give you a false positive NIPT. That's your non-invasive test, because the myomas by themselves release cell-free DNA. Now, once the cell-free DNA is released, your NIPT may turn equivocal, may show an anomaly which you really don't have. And that's why it's termed as a false positive NIPT. If you're interested in knowing more about it, you can check on this book by Lockwood, a pretty recent article also telling us that the NIPT may turn false positive. So there are some other situations again which we have to be aware of when we are dealing with myomas in pregnancy. PPROM, PP, ROM, which Krishnendu just about spoke of, preeclampsia, fetal growth restriction, and fetal demise. Now, all these factors, actually, in the presence of a myoma, there's no increase reported in several studies. So we don't really have to worry about it, especially preeclampsia. We'd be very worried with a large fibroid inside or fetal growth restriction. The other problem is FGR, or fetal growth restriction, is often very difficult to diagnose. Because of the presence of the myoma, we don't know our dimensions, we don't get the fetal measurements correctly, and often find the report not very correct. In specific cases, large myomas in certain locations may be the cause of fetal growth restriction. It also may result in certain amount of anomalies, like the abnormal position of a hand, or where the myoma is keeping on pressing on the baby continuously. But these are very, very small instances, and we really don't have to be worried about fetal anomalies because of the presence of a myoma. Rarely, we also have conditions, these I'm just mentioning to complete the picture, like you can get DIC, that is disseminated intravascular coagulopathy. Sometimes one of the large vessels on the myoma may rupture by itself, resulting in hemoperitoneum. The large myoma may produce urinary tract obstruction. You have the resultant hydronephrosis and problems. Sometimes the torsion in the myoma may undergo degeneration, and the pedunculated myoma may turn into what's referred to as a pyomyoma. These are all unusual problems, and we keep our fingers crossed or pray that these things don't happen and worry us. So what do we do when the leiomyoma, the patient comes with a leiomyoma? Work is very simple. Locate, diagnose accurately using ultrasound the site, size, and the number of myomas. I'm very interested in getting all these details because suddenly you may find it's a discrepancy. Is that a fetal part or it's a myoma? Is it a new tumor which we have missed out if you don't do your homework in the beginning? So once you've done all these, then you are happy. If you're still in doubt about your ultrasound, you could use an MRI in certain situations to confirm the location. Antenatal care is just going to be routine antenatal care, taking care of all the points which we do so very well, looking after her anemia, looking after her diabetes and problems associated to that. Now locate the position of the fetus nearer to term and then assess feasibility for delivery. This sounds very simple, but at times you do not know where the fetus is. You can get a transverse lying fetus well above in the upper segment with myomas occupying the entire lower segment. So what would we call for that? So it is very important, but then it can be done nearer to term only. So the options available to you at this time are you have the symptoms, you have the investigations, and the patient may be comfortable going very well with her pregnancy. So our options is if she comes with pain, we think of medical treatment. And in medical treatment, the simplest option is our simple paracetamol or acetaminophen. That would be the simplest option. We liberally give the patient, tell her to use it up to 2 to 3 times a day. And that normally keeps most patients comfortable because it's normally a little bit of discomfort on the surface of the myoma. If you find acetaminophen not working, then you have the option of going for the NSAIDs. You have ibuprofen, you've got ketoprofen, all these drugs. But remember, with the NSAIDs, if you're giving it a little later, you can have blockage of the, PDA get blocked prematurely and result in problems with that. What about patients who are still not having enough pain relief with these anti-pain drugs? We have used opioids for a short term to keep the patient quiet. Very often, if the patient is quiet for a day or two, you will find by the day 3, she is settling down and she's not too worried about the pain. Some people advocated the use of progesterone to quieten the uterus. This is the principle that the progesterone works to quieten the uterus. But reports are really not supporting the use of it. Another method which has been used by some workers is using epidural anesthesia to keep the patient quiet over a period of time. So if the patient is quiet for basically what we are trying to do is to break the pain cycle. And usually the patient may recover after that. Most often, all these measures give adequate pain relief and the patient goes on with her pregnancy without anything worrying. Only if these things do not work, then we think of the other options. But before that, the mode of delivery. The mode of delivery, if normal, we always permit normal labor. In labor, monitor the progress, intervene if in doubt, and if the surgery was any previous difficult surgery or malpresentations are present, then think in terms of doing a cesarean section. So this is the picture. How does one take a decision? You have a myoma, you have a pregnancy, myoma obstructing. Do we take the myoma out? Do we take the baby out and how do we watch the baby growing. This was our experience. This is just a short period over the past 2 years. Our incidence of myomas in pregnancy is around 3.5%, and we have a very high incidence of normal deliveries, vaginal deliveries in that. Our cesarean rates are not really very much. And if we find a myoma there, if it is large, if it is obstructing, we would go ahead with a cesarean myomectomy. I'll come to that later. But the complications which we've had are basically red degeneration. We've had malpresentations. We have had pregnancy losses in around 12 patients and preterm labor in 4. We've had 7 cases of PPH. In fact, one of the cases was a term pregnancy with a 10 centimeter myoma. 2 days after delivery, she started pouring blood, and we just couldn't stop the bleeding. So we had to do an emergency myomectomy, take the myoma and stitch it up, and only then she stopped bleeding. What about antepartum myomectomy? There is fair evidence to recommend against myomectomy regardless of the size of the myoma. I think you better make it very, very clear. Don't jump to do a myomectomy. If you do opt for surgery, the benefit should be weighed against the risks, and you should individualize the patient. No standard statement that it's above 5 centimeters, so I took it, or it's undergoing degeneration, so I took it. Severe persistent pain, not responding to your treatment methods, rarely vaginal bleeding may indicate doing a myomectomy. So when we are talking of any surgery in the antepartum period, please be aware of the physiological changes of pregnancy. Anybody interested can read a very interesting article on perioperative management of pregnant women undergoing non-obstetric surgery. It's available easily on the net from the Cleveland Medical Journal. It gives you very correct indications of what is happening. What are the special preparations we would do? First question, route of surgery, do it open or do it laparoscopic? We will discuss that a little later. Preoperative preparations, you have to think of using a tocolytic, but which tocolytic would work? Again, is a question mark. Do we use progesterone? We are using progesterone because most of these are in the first and early second trimester. Positioning the patient, yes, with a little left tilt. Anesthesia, generally anesthesia is what we would use normally. And lower the intra-abdominal pressure so that you can operate, you do not compress the blood vessels too much. We are using carbon dioxide. Some people advocate using other agents, but we are used to carbon dioxide. We stick to it. We have not had problems. We have to monitor the fetus and think in terms of thromboprophylaxis, especially in some of the very obese patients. I'll show you a simple case, a 23-year-old primey with 5 months amenorrhea and severe pain. Ultrasound, you can see, shows a gravid uterus with a 7 to 8 centimeter myoma on the posterior right lateral wall of the uterus. She was totally asymptomatic. She was counseled and sent home. She went home, but came back after 2 weeks, literally rolling in pain. She came from a place around 200 kilometers from Chennai. She requested termination of pregnancy. What you do, how you do, I'm not bothered. But I want to terminate the pregnancy. So with this severe pain, we tried painkillers, nothing worked out. So we decided to do a myomectomy. Laparoscopy, we couldn't really visualize. These were very early days. I'm talking of a time of really 7, 8 years ago. Today, possibly we could have done it. So we did a simple laparotomy. Now, in the laparotomy, the first point is try and go directly to the myoma. Don't go and put your fancy incision, because if the myoma is on the right lateral, put it there, or if the myoma is high up near the fundus, put the incision there. Once you put the incision, get into the plane of the myoma and start shelling it out. Now here you can see this is 7 to 8 centimeters. So I don't want to make a hole 7 to 8 centimeters. So I try making a sort of ribbonette. I cut on its sides and slowly make it longer and longer and thereby try and shell the myoma out. For want of time, I'll just take you through a little faster. Can you see how that myoma comes up? It's a perfectly round myoma, but this is what I say, ribbon it, and then the rest of the myoma just tends to pop up easily at the end of it. So that's the whole myoma which has come out. So once the myoma comes out, we close the myomectomy or the myometrium as usual. So that's a picture of the myoma. She recovered well, had an LSCS at term, mother baby well. You can see a picture taken post-operatively showing you the myoma bed with the sutures, closing the whole thing down. The issue we have to worry about is bleeding. But usually, if you shell the myoma out, most often you may have 1 or 2 prominent bleeders, which you can pick up and stop. But many times life is like this picture. You have the resources, but you make poor decisions. It can be done laparoscopically too. So to satisfy the purists, in laparoscopy, we have to think of our ports go up. All our ports would be well above the umbilicus, and based on the uterine size, single port techniques have been reported, but we don't really have experience. We would go high up, put the gas, fill the peritoneal cavity, look down, and then decide on the other ports. The entry techniques, use any one of your choice, much better to use one which you're familiar with. But about energy source, you have to be careful. Do not use the monopolar because it normally spreads all around, can affect the fetus and create problems. We've used bipolar and we've used the ultrasound scalpel, or we have just picked up the vessel and coagulated it shut. So this is the picture of a large myoma. She's 9 weeks pregnant with pain. Uterus is around 24 week size. The myoma is about 18 into 15 centimeters. But luckily, it's a myoma which has undergone cystic degeneration. Do we do it or do we not? So that's the picture of the myoma. That's the picture of the MRI showing the myoma sitting on top. So you have your options. You do it either conservative, sedate, and see. Even if that doesn't work, think of open myomectomy or think of laparoscopic myomectomy. So here we just show you a part of that laparoscopic myomectomy. All you're seeing is the myoma. The pregnancy is above it. So that's the, we cannot use vasopressin because it would affect the fetus. But here, we decided to use a smaller dosage only on the region of the myoma. Okay? So with that, we could get a little bit of control of the bleeding. And the principle is just get into the bed of the myoma, because this is a pretty large myoma. I would be in a sort of dilemma whether to do it laparoscopically or open. But the younger generation like to do this only laparoscopically. So this is a work of my son. So they would go plane by plane, identify. I'm not able to speed it up. That's okay. Now I can do that. Yeah. So I'll just take you through that. Once the myoma is out, get the bed, suture the myoma, and finally suture it shut. You can see that. The blood loss is really not very severe. The entire pregnancy, fortunately, is below. We haven't really disturbed it. Now, in this case, we morcellated it and took it out, and that's at the end of the procedure. You can see it's pretty clean and neat after that, although the purists may think it is still bleeding a lot. Okay? Patient went well, delivered a male baby at term, but Remember, these are things only to be done by the experts. The issue again is suturing at myomectomy. Learn to suture, obliterate the cavity. Do not create a dead space, because that's what creates trouble. Since my time is nearly finishing, let's go to the last part of the story. Caesarean myomectomy, rather controversial. The society guidelines advocate against it, but it can be safely carried out if you are prepared. This is a patient with a large abdomen. You can see, you can't even see the umbilicus. It's very well high up. At a cesarean section for a large myoma, please plan the procedure. Incise near the baby to first deliver the baby. That's point one. Once you have done it, the whole uterus is accessible to you. Then you can expand the incision whichever direction to access the myoma. Here you can use hemostatic measures where needed. Most often, once the baby is delivered and you have given any of your uterotonics, the bleeding is very limited. If you're doing multiple myomas, sometimes you may have to do a transcavitary removal and suture in 2 layers. So this this patient underwent a cesarean myomectomy. You can see the baby and the uterus. I mean, the baby and the fibroid. Both are approximately similar weight. So this can be done well. Now, the controversy is that there will be a lot of hemorrhage. So you have to be prepared. To our experience, fortunately, the bleeding has never been severe, especially if you give the uterotonic and you pick up 1 or 2 big bleeders if they are there. This was another primee who had a lap myomectomy earlier. She came with her second pregnancy. In the second pregnancy, she came to us at 24 weeks. They reported 3 myomas on the abdomen, I mean in the uterus. She came actually from Bhopal. She continued her pregnancy. Ultrasound done, this was about nearly 8 years. She has subsequently come and delivered 2 babies with us. She had 3 myomas. Elective LSCS with myomectomy was done. A baby was 2.8 kilos and the myomectomy specimen was 2.2 kilos. So these can be done. I think if you are the patient, you're definitely not going to be happy having 2 surgeries. And if you can do it well, please do it. The patient goes home well. Tissue removal is a controversy. If it is large, morcellation in a bag is technically correct, but very often that does not, it takes a lot of time. And that's the thing we are worried about. So I don't want to show you the bag removal. So be careful, minimize spillage, and this is in a bag, we are taking it out. Uterine rupture after myomectomy, most of the reports do not show too many, but there are a few. So it is a 0.47% risk of rupture at trial of labor. There has been a report of rupture uterus even after a hysteroscopic removal of a pedunculated myoma from the uterine cavity. So one has to be careful. But there was a very interesting case which came up. As they were doing an ultrasound scan, they saw a loop of cord outside the uterine cavity. You can see a diagrammatic representation here. Procedure was very simple. The baby was mature, taken immediately to a theater, operated, and the baby taken up. If the baby had been preterm, we could have considered even reducing the cord and repairing the defect. So all these are problems with uterine rupture. Post-op, do not miss out on the cellularity of the myoma. You have to analyze, go through it. But the problem again is pregnancy distorts the histopathology. So you need an expert pathologist to pick it up for you. So one would have to say, when you have a myoma with pregnancy, as they say, keep it safe, keep it simple. Fibroids may be left alone in most cases, but watch and intervene if needed. When you come across a fibroid, carefully assess it and decide what's best for that patient and do it well. We must be preventive, protective, and positive with our pregnant women. And this is the attitude we must take. Thank you for your patient hearing.
Excellent talk, Dr. Korean.
Thank you. I still haven't got too many wrinkles.
I'm so happy to see your son operating also, as you mentioned, and he's also becoming a very good
Doing more than me,
endoscopy
I'm not.
surgeon like you. I think we have a chairperson, Dr. Nitin, also with us. I have not seen him talk today.
He doesn't seem to be there.
Okay.
You can give
Yes,
a
sir
last
is there.
comment
Sir is there.
for the session. Dr. Korean, excellent presentation as usual.
Oh, thanks,
A
Parag.
pleasure listening to you after a very, very long
Nice to see you after so many years. Nice to see people like you also growing a little bit older, huh?
Sir, every slide of yours was so fantastic and such a pleasure to listen to you.
I believe
And
that
I'm very happy that Tarun is chosen obstetrics and he's doing wonderful as an endoscopic surgeon also. So it's a pleasure that the youngsters are doing good obstetrics along with the other things.
Good evening, sir. Very witty as expected.
Oh,
I'm from Hyderabad.
I couldn't see you smiling, Faima.
Yes, sir, I'm always smiling.
No, because I was talking. Anyway, thanks.
Thank you.
You had a good audience out there. Thank you very much. Anything I can answer your questions? Do you believe in cesarean myomectomy or no?
I do.
Very much, very much.
I think
Very
the days of not doing it are gone. We have to do it. And but this point of entering comfortably is very, very important. I learned a bad lesson once when I put a low transverse incision and found that the baby was above the umbilicus. So I had to put another incision on top, take the baby out, come back, repair that and this. After that, now I'm very, very sensible. Good.
Yeah, that's a good experience to be shared. Thank you so much, Dr.
Thank you.
Korean. And I think all the three speakers were excellent. I would like to thank Dr. Sarita, if you are here, Dr. Parag Beniwale. Thank you so much for having us here and the other chairpersons with me. I cannot see them right now. So thank you so much. It was a wonderful experience seeing everybody after a very long time and learning a lot at the same time. Thank you so much.
Thank
Joseph,
you,
we're very
Lisa.
much
Thank
here.
you,
We were
Madhuri
spellbound
and
by Dr. Joseph's talk on fibroids and in pregnancy. And really wonderful to see the laparoscopic myomectomy on a pregnant patient. So did she go to term and there was no disruption of the scar?
Oh, she went to term, she delivered. She's come for the next delivery also. She's perfectly okay.
That's fantastic.
No, wait a minute. The delivery
You've done
was C-section.
some myomectomies at cesarean section, but
Delivery
definitely
was
not.
by C-section, not by normal, not normal. She wouldn't progress normally. But after plain myomectomy, lap myomectomy, we try any number of normal deliveries, but not at pregnant women, no.
Your questions are just coming in just now.
Oh.
Somebody is a Redmi 9 Power is asking the question, subserous fibroid of 10 centimeter with 20 weeks gestation, can trial of labor be allowed at 20 weeks? No, I think this must be at term.
No, she must be, they must be waiting for term. At term, definitely you can go ahead. Because that myoma is way out. But as I said, you can have dysfunctional labor sometimes. Because the myoma on top will be controlling the contractions. The cervix may not dilate, in which case we end up with a section. Okay? Yeah.
Sir, our professor used to say that if there are no questions, either the audience hasn't understood anything or they've understood everything. I would like to say that your slides were so beautiful and there was an explanation for everything. So, I mean, the doubts are not there at all.
Oh, thank you. Thank you, Dr.
It was a
Gupta.
brilliant presentation.
Thank you very much. Thank you. I must say a special thanks to my friend, Dr. Palniappan and his assistant, Dr. Malvika, for involving me in this, because normally they get all the younger people to do that.
That's why we chose you, sir.
In ICOG, we get seniors like you.
You get seniors. Okay, good. Anyway,
Pleasure.
I enjoy talking anytime to an audience who's willing to listen. Even if 5 people are there, I don't mind. Thank you very much.
Thank you.
Thank you,
Now,
sir.
Malvika,
Thank
let's
And
move
we're
ahead.
always young at heart.
Malvika, let's move
Can
ahead.
yes, can I please be allowed to share my screen?
I have stopped sharing, so you
Yes,
can.
ma'am, you can.
Yes.
Dr. Kurian, till then, there's a question in the audience, in the chat box. May I request you to have a look at it, please?
Incision in case of LSC as a term for a 10 centimeter fibroid depends on where the fibroid is. If the fibroid is low down, I may incise above, take the baby, and then do it. Okay, thank you.
Thank you.
Thank you so much, sir. Thank you so much for that insightful session. We'll head out to our next session, which is a very interesting one on emergencies in pregnancy. Our moderator for the next session is going to be Professor Palniyappan, who is the Foxy Vice President-elect, Professor and Head of Unit Obstetrics and Gynecology at Ramchandra Medical College. Sir has won the Indumati Javeri Award in 1994 and the Young Scientist Award in 1996. Sir has been a senior overseas.
Thank you. Thank you. You can introduce the panelist, Malavika.
Yes, sir. We'll go ahead to introduce the panelists.
Yeah.
Our first panelist is Dr. Mitra Saxena. Madam is the director of Sri Ashwini Saxena Hospital. Madam has been Madam has been an organizer for state level conferences and workshops in ultrasound colposcopy. And Madam has received Foxy Dira Award, Foxy President's Award for Appreciation Award in 2023. Madam has numerous publications in her name.
It's okay. It's okay. Just thank you so much. We have to be brief.
Yes. Our next chairperson is Dr. Poonam Goyal, the HOD of IVF and Infertility Max Super Specialty Hospital from Vaishali, Delhi. She's the director and HOD of OBGYN at Panchsheel Hospital, New Delhi.
Thank you.
Honored to have you, ma'am. She is a chairperson of Foxy Safe Motherhood Committee, ICOG Governing Council member, and executive member of.
Okay, thank you.
Our next panelist is Dr. Famida Banu. Madam has done her MD and DGO from Osmania Medical College, a gold medalist, and has conducted live surgical workshops. An honor to have you here, ma'am.
Thank you.
Our next panelist is Dr. Juhi Agarwal. Madam is a professor of Department of Obs and Gynae at Gandhi Medical College, Bhopal. She has numerous publications in national and international journal, and she has also received numerous awards.
Thank you, Malvika, and very good evening to everyone, all the stalwarts here. Thank you. Thank you, Malvika.
Thank you, ma'am. Our next panelist is Dr. Shailendra Jadhav. Sir is the Chief
It's
OCCU
okay, Malvika. It's
of
okay. Yeah. I'm the chief
Curate
of the
Hospital.
OCCU. Otherwise, very good evening to everyone. And let's proceed. Hello, sir.
Good evening, Shailendra.
Good evening, sir.
Good evening, sir.
Good evening.
Our last panelist is Dr. Manoj Chalani. Sir is the director of Ayush Hospital and Test Tube Baby Center at Raipur. Honor to have you here, sir.
Great. Regards
Without
of the
any-
city of Lake City of Thane, and we can start.
Yeah. Thank you very much, Malavika, and the panelists for joining here. And after 3 lovely talks, I'm just going to do a panel, and I'm sure the panelists are lovely too. And most of them, I think I've met everybody, almost everybody, a couple of conferences. And thanks for being a panelist in this particular panel. And to be honest to the audience, the panelists have not been given any questions, and so they don't know what we're going to do. And so allow me to share my slide. And thanks to Dr. Parag and Dr. Parul Kottadabala, and of course, Dr. Sarita for having made me the moderator of this particular panel. And we are going to do 2 case scenarios. You're able to see my screen? Are you
Yeah,
able
we
to
can see.
Yeah, okay.
We can
So
see
I'm
your
going-
screen.
Yeah, so I've just made it as angry birds because the abdomen looked angry many a times. And so only we left to pacify the abdomen. And that is the reason why there were nothing else. And so we would go on to the case and we will move on with any panelist answering. Let me ask a particular panelist and we will ask questions though. So this was a primee who was 31 weeks plus 5 days, a known case of hypothyroidism.
We cannot see the slide, sir. Only your Angry Bird is not playing, sir. Angry Bird is not playing.
So the second slide is not moving?
No slide at all, sir. It is just the desktop.
Oh, okay.
So please open the presentation.
Just give me a minute. Good. Able to see now?
Yes. Sir, make
Yeah.
it full screen, sir.
Yeah, just
Sir, make it a slideshow.
Now you're able to see?
Yes.
Yeah.
Fine. So this was a 31 weeks, 5 days primary gravida, except for hypothyroidism, nothing very great. She came to the casualty with pain abdomen, and this was a real life case. Pain abdomen for 1 week, vomiting, constipation for 1 week. First, second trimesters were uneventful. In the third trimester, she was admitted a week back around 30 weeks for preterm labor, and she was on nifedipine tocolysis and steroids were covered. And we did not think in terms of giving any MAC-self at that point of time. And she gave a history of query thrombocytopenia from the referred hospital outside. So the admission labs on that particular day, hemoglobin okay, total count was okay, platelets were 1.5, so we did not bother much about it. She was given preterm counseling and surgical opinion was sought. Because the tenderness in the right iliac fossa, she's been treated for preterm labor a week back and we didn't think of preterm labor. So we thought it should be some surgical condition. And so tenderness in the right iliac fossa, increased TC, total count, worsening signs of local peritonitis were seen by the surgeon said. And we did an ultrasound abdomen. Okay, the fetus was fine. Ultrasound abdomen was inconclusive. They did not give anything because the abdomen was masked by the pregnant uterus. Diagnosis of query appendicitis and the repeat total count was scheduled for. She was started on IV piperacillin, antibiotics and analgesics, and she didn't settle with it. And so now, Dr. Mitra, would you want to think in terms of doing a diagnostic laparoscopy and proceed, or what would you want to do at this point of time, Dr. Mitra?
No, I would not go for diagnostic laparoscopy, as in, I would first also like to know her thyroid status. And she had vomit. Sorry, the latest thyroid levels. Is she being given?
Thyroids were normal.
Sorry, okay.
TSH was normal. She was a known case of hypothyroidism, but thyroids
yeah.
were
No, just I want to know because she had history of constipation as well. And her symptoms are pointing towards appendicitis only because she has pain, vomiting, constipation, and tenderness in the right iliac fossa. And actually, appendix is a very big masquerader. So we may not get ultrasound findings basically. And in fact, because she's preterm, we've also given antenatal corticosteroids. Am I right?
Covered.
So that could. And actually, I have had a similar patient who had appendicitis. I kept her in the category of preterm labor and gave her antibiotics and steroids. And actually, I landed up with ruptured appendix. So instead of thinking about diagnostic laparoscopy, I would get a surgical opinion and think about look and see laparotomy. 31 weeks, I don't think diagnostic laparoscopy, I mean, personally, in my setup, I cannot, maybe somebody who's very proficient, but the diagnosis of appendix has to be ruled out before we. Another thing is we've also given a very good antibiotic. So we have to see the response. But I would say that appendix is I would put that as the first differential.
Okay, fine. So agreed. And what happened was the subsequent day, the C-reactive protein was 1.2, and at that point of time, there were a lot of scrub typhus going on in Chennai, so the physicians wanted to do that as well. So she was seen by a physician, surgeon, and everybody saw, because we thought it is beyond our obstetric point, and so we could get the help of the team. And the dengue serology was negative too, and the total count increased to 14,500. So the surgeon was very particular that he goes on and sees what happens to the appendix. And so they decided to go on and do a laparoscopy, and she was almost 32 weeks at that point of time. Dr. Famida, anything you want to add on, or we move on?
One thing what's puzzling me is the pain, tenderness in the right iliac fossa.
Did not come down.
Second trimester, the point of tenderness, usually it goes up. It usually the lumbar region. That is
she's pregnant also, isn't it?
Yeah, pregnant. Mostly in pregnancy, the appendix position goes up, and we should have high degree of suspicion. With a WBC count, in spite of antibiotic, I will not have any hesitation in putting a scope and saying.
Okay, fine. Thank you. So Mitra didn't agree. So you agree to scope her. So we'll see what happens.
I mean to say, look and see.
Fine, I agree.
But,
No. In Revari, you can't probably, but you need to agree with the point that we need to do something for the appendix.
Yeah, you can't leave. Yeah.
That's, we are not Dr. Kurian. Everybody cannot do laparoscopy at 32 weeks. I agree. I was in a tertiary care center. So what happened was,
Sir, just one question before you proceed. Just one question.
Shailendra, yeah.
Sir, there was fever, sir. Sir, why
fever was also there. Fever was also. Yeah, Shailendra.
Okay, sir, one question I would like to ask is whether subacute intestinal obstruction was considered as a differential diagnosis?
Was considered. The surgeon came and saw, and they did not think in terms of that. So let's go ahead and see what happened was we put in a laparoscope with the surgeon and the obstetric. I was there too. Laparoscopic entry was uneventful, and there was a huge clot in the anterior wall of the uterus covered by the omentum. And the clot was removed to discover a bleeding vessel from the anterior surface of the uterus. She's 32 weeks pregnant now. And the bleeder did not stop with pressure. And they put a pack, a small gauze which they inserted and put it on. And she's pregnant and 32 weeks. How will the bleeding stop there? And they put a Surgicel which was also there. And so the bleeding did not stop. Dr. Poonam, what would you want to do at this point of time? So nothing stops.
The thing left is that if we can some stitches to control the bleeding.
You want to take a stitch? Baby is inside. 32
deliver the baby.
Or you have to deliver.
Shailendra, you want to deliver the baby. Okay, fine. So this is the one which you saw. So that is the clot. See, that is the entry. And nothing happened. You will see now slowly when we try to dislodge the clot and see, is there a rupture? What is there on the uterus? That is with the atraumatic forceps and anterior abdominal wall, and that is the clot we're trying to dislodge. Okay, so we go on, and we were quite skeptical. The whole theater was in silence, and we removed that omentum which moved, and you're able to see the antenatal uterus. So that was the clot which we tried to remove. And there were a lot of hemoperitoneum inside. So that was the vessel which started bleeding there a little lower down. And slowly what we thought was we put in Surgicel, and the blood was trickling on the other side. And so we tried to use a gauze, and the gauze wouldn't do anything. It was of no help, and the bleeding was going on, trickling down.
Surprisingly, her hemoglobin was 11 gram%.
Yes, because I think she would have just started bleeding the
chronic bleeding, yes.
Maybe it was only very
slow trickle.
So the tenderness was due to this, the tension in
momentum.
Maybe
momentum and all had made a
reactionary
maybe.
Just wait for the surprise to see. Then what happened was we went on. See, so much of blood inside already. So it probably bled and then it clotted, bled and then clotted. And so much of blood inside the peritoneum. And we put a Surgicel, it did not open. This was all the vessels all over the uterus, and we went around the entire uterus. And so the surgeon said we could take a few stitches, and could I use cautery and then burn? I said, no way. There is a baby inside, and there's an obstetrician standing next to him. And so what would you guys want to do? Dr. Juhi, you are there?
Sir, yeah. I feel we should convert it to an open
laparotomy.
Yeah.
Yeah. First convert it into
I would have been
I would
I
just
would have
want
been
to jump and
comfortable.
see.
No, no,
Yeah.
I also agree with you.
LSES needs
So,
to be done.
laparotomy was done, LSCS was done, and usual ways. I did the cesarean and 32 weeks, and placenta membranes were delivered easily, and the uterus was externurated for exploration. And
So,
to our
sir, it was
surprise,
a percreta or accreta,
no, no,
or what
nothing,
was the
nothing.
reason?
No.
Just
Nothing.
give me a minute. The anterior surface of the uterus was covered by extensive ramification of blood vessels, which we saw on the laparoscopy and onto the left side. So now uterus was closed in 2 layers, and there was a huge hematoma noted on the left side of the upper segment from the vasculature, and hemostasis secured with very great difficulty by taking multiple bites here and there, and then appendix, both tubes and ovaries were absolutely normal. You couldn't have had a better looking appendix, and the appendix was absolutely normal. And this was the postpartum uterus, I mean, half an hour after the delivery. So, I mean, there were absolute ramifications of blood vessels. And so that is the cesarean scar at the lower segment. This was the postpartum uterus. And so now you can make your comments and say, Dr. Manoj Chalani, are you there? Manoj? Manoj is not there. Okay, fine. Dr. Shailendra, would you want to comment on what would you want to think in terms of?
No, I think I just said, once I put in a scope and see that the bleeding is not being managed, I would have converted it into an open, deliver the baby and manage the uterus. But otherwise, a great case, great stumping case. And my initial diagnosis would have been an appendicitis or a subacute intestinal obstruction.
Fine.
So I think whatever done, great management and kudos.
No, we've not finished yet.
It was.
And the story continues, Dr. Mitra.
Okay, story continues.
Yeah, and it's a primary cesarean section, and I'm quite confident doing a cesarean section, and it's almost my 25 years of in that place. Oh, but then I opened the bladder. I don't know how the urine was blood stained, and so then we went around and saw the bladder rent noted on the dome of the bladder about 2 centimeters. So we were in the tertiary care center, no harm. So we closed the uterus with bladder with Vicryl 2.0. Hemostasis secured, and then hexocath was placed intraperitoneal drain. And
Sir,
then
this case is very strange, sir. I mean, I have never seen such a case. I mean,
absolutely
there is no sign of injury, no accreta, nothing,
absolutely
no scar.
That is why, madam, they say obstetrics is a difficult ball game. You can get stuck with
Dr.
even
Palani,
after 25 years.
the panelist is going to ask you a question.
Very
I
well.
will have the audacity to ask, have you reported this case? Because this is so unusual.
Fine. So now, Dr. Poonam, you tell me, how do you think the bladder got open?
I think when there was such an hemorrhage, and sometimes you tend to make mistake because the field is not very clear at that time. And maybe the bladder was adherent because there are signs of infection. Patient
bladder wasn't adherent. Then we went and looked into the conditions which were prone for intraoperative bladder injury. And then here you see a lot of conditions like that. And in the last, I put in red color, if you see, that is from the evidence, preterm cesarean section where
the lower segment is not well formed.
So I did push the UV fold, and the bladder went down nicely. And I was quite confident. We had a big team, so I was not worried to take out the baby. But then, in a preterm cesarean section where lower segment is not well formed, or you may accidentally injure the bladder.
It was
however good you are and however careful you are. So the lesson learned was the second lesson which we learned. And then we went and did a literature search. And then, of course, bladder repair, everybody would agree. So you would keep this thing for 14 days and go on. So yeah, indwelling catheter for 14 days. Let's not discuss that and waste time. So now the question is laparoscopy safe in advanced pregnancy, like 32 weeks? We just saw Dr. Kurian doing a myomectomy at 16 weeks, and then we discussed. So what is your take? Dr. Juhi, you want to answer that?
Yeah, but in my opinion, I don't feel that it is safe. I mean, this word safe is something which
very
is
subjective.
Yeah, it's very subjective. So I don't think it is for me. If I am a surgeon, I would feel never to put a laparoscope in a full-term pregnancy or in an advanced pregnancy.
No.
And that too in a patient where pathology is, of course, in such a big uterus, you won't be able to see even the pathology with laparoscopy. I mean, I feel once I open the uterus, I open the abdomen, I will be more comfortable, and that is how I will do justice to my patient.
Okay. I'm sure Dr. Famida would want to answer this. Yeah, Dr. Famida.
Ask the question to the moderator. what might have caused that high vascularity on the uterus? You might have.
We are just coming to Dr. Famida.
It could be endometriosis, old history of
No, it is not
endometriosis or anything.
endometriosis. We'll come to that. We will
Sir,
not
I
leave any
think-
stone. Now answer
Sir,
this
I
question,
think
Dr. Famida.
it will not be wise to do the laparoscopy in this much size of the uterus, because posterior surface you won't be able to see till end if there is any abnormality or anything there.
Okay,
That
fine.
is what I feel.
Time from laparoscopy to laparotomy if you have taken a proper consent, but it is worthwhile putting the scope, because you can do it. Only thing is you have to take the position of the camera scope port very higher, 5 centimeters above the upper end of the uterus. Second thing, madam, it is all the choice of the surgeon's
I
choice.
think, sir, your question says, is laparoscopy safe in advanced pregnancy? So I think the direct answer is it's not safe. It is safe if provided the person who's doing, the team are doing, everybody is counseled and you are ready with every alternative. But the simple answer to this, in advanced pregnancy, this is not recommended that everybody should venture
So
this.
let's not jump to conclusions.
Laparotomy, yes.
Let's not jump to conclusions. Just give us a minute. Let Dr. Famida finish the answer.
Yeah.
Madam, it all depends the choice of the surgeon. Somebody may be more comfortable with the laparoscopy, somebody may be comfortable with the open. It all depends on the individual. It is like same in obstetric. Some like to do vento, some like to do forceps. It all depends individually the choice of the surgeon. I definitely prefer scope. Suppose that cause would have been simple and Dr. Palaniappan would have managed, and that will the end of the story. Because it is a very rare and very unique case, he has converted into laparotomy. Anytime we should not have any ego to convert into laparotomy. We have to accept the limitation. When it is not possible, definitely we have to convert into laparotomy, and we have to take the consent like that only. We are attempting laparoscopy, possibility of successful laparoscopy is there, yet we are humans. We may have to convert laparotomy when indicated.
Fine. So thank you very much, Dr. Famida. So the two of them were very vociferous and angry at me for having done a laparoscopy. So the question, Dr. Kurian did a myomectomy on a pregnant lady. I've never done. So if there is a case which needs to be done, I'll refer it to Dr. Kurian, right? There are no recommendations. So it is not safe, right? But he did it with a pregnant uterus. So that's where we progress. So you have the SAGES guidelines, and it is absolutely very clear. Only after having got the case, we all went back into and studied the SAGES guidelines, which said guidelines for diagnosis, treatment, and use of laparoscopy for surgical problems during pregnancy only. So here it says preoperative decision-making guideline number 8, laparoscopic treatment of acute abdominal disease has the same indications in pregnant and non-pregnant state. Evidence moderate to strong. Dr. Mitra, that's for you. Laparoscopy and trimester of pregnancy. Laparoscopy can be safely performed during any trimester of pregnancy. Evidence moderate to strong. Treatment patient positioning guidance. I'm sure we will leave this. We'll skip the slide. If somebody wants to take a photo, they can. And we will not do this and waste time. Insufflation, all of them said 10 to 12, 12 to 14, whatever. So you could keep pressures at 15 millimeters of mercury can be safely used in pregnant patient. Intraoperative carbon dioxide, if required, we'll give VTE thromboprophylaxis, and appendectomies can be performed safely. If there is an appendix, what we thought of could be done. And so that is the recommendation now. So we could go ahead and do a laparoscopy, provided your center is okay to do so. You can. So the answer is it is quite safe in pregnancy. Whether you would be willing to do or not is a different question. And so we would probably think in terms of doing this case a couple of years from now, because we've all become experienced a little later. And once we start, we will probably do. So what happened, Dr. Shailendra, you were asking, only after the case went on, we did and got into and we saw evidences of what happened with this. And this is a 1960 article, British Journal of Obstetrics and Gynecology, BJOG, rupture of varicose veins of the uterus associated with pregnancy. So that is what finally we came to a conclusion that, oh, it was a varicose vein of the uterus which ruptured. And so we could find one more evidence. And so absolutely rare case. I'm just looking for one more case to publish this article somewhere. And so this is in 1960, and then a case of spontaneous rupture of the uterine superficial varicose vein.
Sir, one question. Was this patient obese?
Absolutely no, not obese. Okay. So this was the paper which came in 2019. And so we had only 2-3 evidences to go. This was our own Indian journal, which I could get into. And so this was a rupture of the varicosities of the uterus. So why not have varicosities in pregnancy? This was a varicose vein of the uterus, absolutely different too. So OBG, this is only the conclusion of the first case. It involves medicine, surgery, pediatrics. Skills and surprises have to surpass our knowledge to manage cases instantaneously. And we have to agree with all of you that teamwork works. There were surgeons, there were pediatricians, and there were physicians, and everybody, anesthetists had to do a wonderful job there as well. So we move on to the next case. And this is case 2. I would put it as double trouble. It's definitely not twins at all. Don't think I'm doing a twin pregnancy, which is very common. So this is Mrs. X, a 21-year-old lady, second gravida with previous 1 abortion. Came to us at 39 weeks plus 4 days only. That is, she came near term. Uterus, known case of uterus didelphys with the pregnancy at the right horn, and steroids were covered in an outside hospital for whatever reason at 34-35. She came to us for safe confinement just because it's a tertiary care center. They were admitted the patient here. No history of diabetes, hypertension, asthma, no CAD, CKD because of the uterine anomaly. They thought about renal anomaly, and all that was ruled out in the outside hospital, and no history of any blood transfusion, bleeding, antepartum hemorrhage before. The first abortion was an embryonic demise at 45 days, medically managed somewhere outside. That's for the first time. We're seeing her for the first time. Uterus relaxed, not contracting like a normal, blah, blah, blah. Cervix was soft. And when we put in a speculum to say, oh, uterus didelphys, there was only 1 cervix which was seen, posterior 2 centimeters long with a very poor Bishop score. And so we thought, what should we think we should do? She came in for a delivery. Dr. Shailendra, would you want to induce her at this point of time, or what would you want to do?
Okay, to be very truthful, yeah, there was just 1 patient of uterine didelphys, but she had come in very active labor at 6 centimeters. So she delivered normally, but otherwise, the other 5 or 6 patients which are managed, they were kept for cesarean sections. So if you were to ask me personally, yes, fine. I would, under strict monitoring, allow a vaginal trial in the time, but a section will be required only for obstetric indication. She's 39 weeks, so there was no question of preterm labor.
Dr. Famida, you want to differ with them?
No, sorry, sir, there was interruption. I could not hear.
I said that we allow a vaginal trial for this patient, and then section is done for any obstetric indication only.
Sir,
hello. Yeah, Dr. Famida,
can I?
Weight? What was the estimated baby weight?
Baby weight was 3 point something. Average baby, nothing very big.
Still, to be uterine didelphys, I may err towards the
Correct, but Dr. Famida, please get the point. There was only 1 cervix seen there. It was not a didelphys at that point of time. So please get, that was the history given, but she had only 1. So
basically, it could be a bicornuate uterus with a single cervix.
Fine, okay.
Sir,
Fine. So
I would.
Yes, Dr. Mitra.
Yeah, firstly, I would also like to see, because you said it's a didelphys, a uterus, and only 1 cervix. So what is the continuity of that cervix to that horn, if the sonologist can tell me? I would really like to know. It should not be a pregnancy.
That cervix has to continue.
That she's 39 weeks plus 4 days. I don't think we will do an antenatal ultrasound to say whether the horn or whatever is communicating, not communicating.
No. How, sir? So what I mean to say is that this horn having the baby and the cervix, are they in alignment? We can very well see even at term by transvaginal. Secondly, at 39 weeks, she's already with very poor Bishop. So,
Dr. Mitra, Os was admitting 1 finger, and that cervix and that uterus only had the baby. There's no doubt about it. You don't have to do ultrasound. PV was there, and
I would like to confirm it. Yeah. Okay, fine. If it is confirmed, then no problem. Definitely, we if the pelvis is good, baby is not very big, and she's no other, as you said, she's fine. We can wait for spontaneous labor. She's 2.45. Okay.
It didn't happen. And that was the estimated fetal weight 2.5 kg baby. And she was planned for induction and mifepristone, Foley's catheter, blah, blah, blah. All that we did. Let's not go into the controversy of what induction method we use, because we will be not taking
Sir,
consensus.
I was just telling ki mifepristone can be given in live
We
babies.
do give mifepristone for induction of labor, followed by a Foley's catheter gel for right.
Yeah, Foley's catheter will do. That is what I wanted to
work
say.
well.
Give
It will work
200
well.
milligrams.
But then, sir, don't you think Cerviprime gel would be much safer?
After that,
Ibuprofen gel.
that's what I'm telling. So then we had to put a gel after that. So here what happened was the Foley's expelled, and then what happened, the uterus, the cervix started dilating. So cervix became soft the next day morning. 1 centimeter long, 3 centimeters dilated, membranes were bulging, presenting part at -3 station, and ARM was done. A clear leak was noted, and the 20 grams of clot was removed. And this ARM, I did the ARM, so I know what happened. Then after a couple of hours, we said start syntocinon augmentation, and CTG was continuously good. She was on intrapartum monitoring, and nothing happened. Any other doubts and questions at this point of time? Why did we induce? So that's a bigger question. We will not answer at this point of time. So at 12:40, that is 3 hours after all that was done, the uterus was contracting and cervix became 4 centimeters dilated, and FH could not be localized by the CTG machine. There was a drop in the CTG, and it was localized by scan. Of course, we have a scan machine, and heart rate was 80-90. So in view of a persistent fetal bradycardia and query abruption, we saw a clot at the time of ARM, and we kept uterine rupture in mind, but abruption was also kept in mind, and patient was shifted for an emergency cesarean section, right? So anybody would have wanted to wait at this point of time?
Sir, actually, I just want to point out that since after 3 hours we watched and it was just 4 centimeters. So protracted labor was any which ways there.
No, if you keep 1 centimeter per hour, it is okay.
It is okay.
It is okay.
So it was 3 centimeters to start with, now when you started.
She was 1 centimeter dilated. So
You
she has
have started induction.
No, you started syntocinon after 3 centimeters, isn't it?
Correct.
Finally, when you induce, there is bound to be some amount of dysfunction. So at 39 plus weeks, I would have done elective section, but I really admire your guts. So let us see what suspense you are holding for us.
No, not much suspense now. So this was the fetal heart race. In this case happened last month, and so it is very, very interesting. So we could not, the FH was just going on like that, and you can see no FH at that point of time. So we had to open up, and this was the uterus which we found. So that was a linear rent on the uterus, and that was the other horn which you can see on the side. So this was the other horn. That was the non-communicating horn, which was a little big, and this was the pregnant horn, and that gave a lateral tear like that, like a J-shaped tear, rupture. So luckily the baby was okay, and we intervened at the right point of time. Maybe the next 10th minute section was done for her, and so we could save the baby. So uterine rupture noted at the lateral wall of the right side of the uterus, extending 2 centimeters below the fundus superiorly till the UV fold. Uterus is closed in 2 layers, and the hemostasis secured with a IP drain. 1 unit of blood was given, and then minimal PPH controlled misoprostol. Baby was 2.9 kg, and baby is in the NICU on cooling therapy. And now, of course, this happened a month back, and the baby got discharged quite well after the cooling therapy.
So we could not suspect it was rupture.
But sir, actually, anticipated weight was 2.4 kg, isn't it? And the baby turned out to be 2.9 kg. There was
how much justified in giving 200 milligrams of
200 we never give, sir.
Because of that.
That is messages.
Because we never.
That's always the clinical estimation.
It is not the rupture. It is not the inducing agents. Of course, the uterus was quite weak. We'll come to that. So now coming to uterus didelphys.
I was thinking, how come she went up to 39 weeks with didelphys?
Actually, that was my. Like she was lucky enough to go till 39 weeks in such a small.
Actually, that's what I said. That Dr. Famida also said. We people would have, sectioned her earlier because we are in single setup. So it's a scary thing.
No.
But you have a good team.
No. See, you have to understand there was only one cervix. So it was not uterus didelphys. So at that point of time itself, we had a difference of opinion. So we thought it could be a communicating or a non-communicating one because we did not see 2 cervices. One cervix.
And madam, moreover, dialysis is not an indication for elective LSCs. Of course,
No,
you
you're
can go
not
for
wrong in doing elective LSAs. These are lessons learned because there was only one cervix and she looked favorable with the induction. So we thought we'll go
You
ahead.
can always try.
Many
with
times,
strict
sir, ऐसा भी
monitoring.
होता है ना, people come with the reports and they are saying diadelphus and report is
Right.
normal.
So now my question is, Dr. Shailendra, how would you
Yes,
want
sir.
to diagnose a uterus diadelphus and what would you want to put into the consideration of uterus diadelphus?
Oh, well, see, if it is unregistered patient and uterus diadelphys has been diagnosed when the patient is in labor, which though is difficult, technically difficult. But having said that, antenatal diagnosed uterine diadelphys, I would really, as Madam already said, that place her for an elective cesarean section. Because there are a couple of things that I would like to consider is whether I'm working in an institute or whether I'm a private practice. So whether I'm alone or whether I have my entire unit with me. So if I have my residents with me, then of course a vaginal trial can be given with the continuous CTG monitoring and intrapartum this thing. But otherwise, yes, even I would not take the risk and go ahead with the cesarean section.
Fine. So then we looked into and we thought, what could this uterus be? This is all after the rupture.
Afterthoughts, yeah.
Afterthoughts. And so then we went into the guidelines and saw the ESHRE and the European Society of Gynec Endoscopists gave a little different from the ASRF guideline. And so they said here, they said the diadelphus has to be U3BC2. Right? But whereas what we saw was actually not uterus 3, we saw class 4, probably a hemiuterus with a rudimentary cavity communicating or not communicating, and normal vagina, long non-obstructing vaginal septum, but we did not see any septum. Or it should have been on class 6, that is an unclassified malformation. So that is what we would have seen here. So probably our case was class 3 here or a class 6. So that should have been our case because we did not have 2 cervixes at all. So we went into the literature and then start bugging each other. And then finally, this is what the conclusion we came into. And coming back to our uterus diadelphus, and then, so we went into case reports and discussions thinking that it is diadelphus. So should we do a cesarean section electively or a vaginal delivery? Don't hit me at the end of the webinar is over, so don't hit me. There were 3 cases. This is not ours. This is somewhere else case reports. Okay, none of them are ours. So here what they did was, you can see the details of the cases. And so they had given her a vaginal delivery for one case in case 3, and case 1 and 2, they had done a cesarean section, elective cesarean or emergency. So they went into labor and then they have done an emergency C-section and baby weights were reasonably okay. So then we pondered and say, is there a role for trial of labor and diadelphus? Oh yes, there are reports. And so now the question is, we were all pondering whether you should give mifepristone, misoprostol, blah, 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 oxytocin, yes, no, or do we have any low dose oxytocin and things like that. Dr. Mitra, you want to say that in this such a particular case, not a diadelphus, maybe with a unicorn, I mean a horn, would you want to give a low dose oxytocin or would you give oxytocin or not if she's in labor?
Sir, I would really be skeptical in these types of uterine anomalies because it will be a very one thing is there, that natural forces of labor, even there you can have spontaneous ruptures. So one has to really keep the index of this complication in mind, especially when you have a smaller sized uterus. And so augmenting with oxytocin, I personally would not have the guts to do. Spontaneous, smooth labor, good progress, no fetal distress. Okay, fine. Like one of the cases you've shown, she delivered a 3.2 kg and a spontaneous labor. The other 2, the babies were smaller. So inductions, I would not go with a big baby. I mean, everything adverse. I don't have the guts personally. I would choose cesarean section, guarded. But yes, if they go into normal labor, it is smooth. We can follow her up closely.
Okay, fine. So we searched into the evidence, and even I wouldn't say that C-section is a wrong thing. So even I would have done a C-section if it was a diadelphus and I found 2 services, I wouldn't have even induced her. C-section was usually performed due to soft tissue dystocia. So here also we found that there was one another horn which was attached to the lateral wall of the uterus. It was not in the fundus. So that would have acted as a dystocia for the baby to have come down. So usually cesarean sections are performed for 2 reasons. One is soft tissue dystocia and second is for a breech presentation.
Breech.
It was cephalic though. So usually such type of uteruses, there is breach. So they've analyzed and said, oh, you could try a normal delivery if she was a cephalic presentation of vertex and then progress of labor is good. But why do we do elective sections? The reasons for having done an elective section, one is soft tissue dystocia, which is what we had here. And usually the presentation is a breach. I mean, anomalous uterus with the breach, we have two indications. We would obviously go ahead and do a C-section. That was the case report which came in 2020, a very recent case report which we went into and then saw. So they concluded saying that cesarean section here is a sufficient indication, but not an absolute indication. So please understand that we need to phrase our words very carefully. You're not wrong in doing a C-section, but it's not an absolute indication. So we have to individualize case basis. Uterus didelphys.
In fact, sir, with uterine anomalies, we have a higher incidence of malpresentation, which makes it easier for us to justify a timely cesarean section. Sometimes it's easier for us when we have.
So here is another article from the ICOG committee opinion, and they said rupture rate in an unscarred didelphys uterus approaches the rupture rate in an unscarred non-anomalous uterus. So would you like to read that? Oh, I didn't like seeing it, but that was the truth. So they said the incidence of rupture in an unscarred didelphys, that is a previous section didelphys, and an unscarred non-anomalous uterus, the incidence is almost the same as 1 in 15,000. So that is what the AJOG's conclusion of uterus didelphys and vaginal birth after C-section. So they were daring enough to give a VBAC in a uterine didelphys, and they said unscarred uterus and scarred uterus, their rupture rates were almost the same in a didelphys uterus. Oh, I wouldn't do so. I agree with all of you, but that is what the literature did say. So the unscarred non-disrupted myometrium is composed of cells that communicate through gap junctions. So this was the physiology which I learned after that. These gap junctions propagate contractions that begin in the cornual region and travel downwards and across the uterus to the lower uterine segment. This results in normal labor if there is lack of cell-to-cell communication, like what happens in a didelphys, as is the case in separate horns of didelphys uterus. The myometrium may not retain its ability to contract its synchrony, and so it may go in for rupture, was the probable beautiful explanation which I had to go through and then see. So that was the
actually very nice, very
explanation which I got.
Very
But all this is after literature search, and you can see 1949, 1953 evidence. So none of us would have even, none of us would have been even born at those days when the evidence came into picture. And so that was the oldest evidence which I could chip in. And so you could have a rupture because of that.
Excellent.
Thank you, sir, because this is so beautiful. The physiology has not changed, actually. Our, brushing up our knowledge is so critical. And thank you, Dr. Palani, for bringing out this,
There are no data to suggest that synchronous contractions of a didelphys uterus are necessary to expel the fetus from one horn. And in fact, in the case of twins in two separate horns, asynchronous contractions allow twins to be delivered in the interval of 66 days. So that was another paper which I pulled out. And thus contractions generated by a didelphys uterus with unscarred myometrium hypothetically have enough strength and frequency to expel a fetus from either of the horns. None of them are my statements. Everything is evidence quoted in BJOG and journals. And so you could have the references. So this is what we learned out of this particular case, and obstetrics is full of surprises. And so to conclude, full of surprises, and we need to surpass it. It's full of obstacles and we need to overcome it. And we need to agree together. Everybody achieves more. And so teamwork works. Now I request the panelists to say whatever you want to say on this, and we are at time. I'm sure Dr. Sarita will be behind me.
Sir, if you have time, I would like to share one of my cases. It was, the same case. It was a uterus didelphys, and the patient was married, and after marriage, the patient was pouring pus from her vagina. So frequently she used to pour pus, and when we did her per speculum examination, it was a single cervix. Then what we did was we did a diagnostic laparoscopy. So in diagnostic laparoscopy, we saw there were two horns, and one horn was communicating with the other horn, but there was a single cervix, and the vaginal pouch was a blind pouch, and there was lot of menstrual blood collecting in the other horn, leading to endometrioma on that side. Okay. So that menstrual blood was getting infected, communicating through the main uterus, which was actually communicating to the vagina, and thus it was getting infected. So what happened? The blood get collected in that pouch and it got infected, and the pus was flowing through the original, I mean the main body of the uterus. So what we did was we excised the myometrium, I mean the uterus, which was menstruating and the side where endometrioma was developing. But we did not compromise the cervical thing. But still, there was some amount of myometrium left or whatever. Again, she had similar complaint. So what we did was we stopped her menses. I mean, that was just nothing evidence-based. Temporary. What we did was we continued her on OC pills, continuous OC pills, pseudo pregnancy state for at least 10 to 12 months, so that she may not get menstruate and the channel which was actually communicating the excised uterus and the main body may get closed.
Okay.
And to my surprise, she got pregnant and delivered a baby 2.5 kg. I mean, one fine day she came to me that, "Madam, I am pregnant." I left OC pills and so that is what obstetric is. I mean, I suggested her, you never get pregnant because I don't know
Then what happened? Then you did a C-section at term.
Yeah, C-section, and the baby was 2.5 kg, though she landed up in preterm labor, and C-section was done at 35 weeks.
Fine. That's a good ending. Yeah.
Sir, excellent discussion. Just one question I would like to all the panelists, including yourself, everyone. If you really believe in the next life and after birth, would you like to take up gynec and obstetrics in your next life? Well, I would not, because my wife said she's not going to marry me if she were going to take up obstetrics in the next life. So absolutely no.
First of all, I will answer. मैं तो कभी नहीं बनूंगी. I'm going to become a model or something.
Palaniappan, there is one comment. Yeah. Because you said 39-weeker has been referred to you and came late, but you are clever enough to analyze her early first trimester scan. Otherwise, such a small rudimentary horn, anybody would have missed if just comes as an unbooked case at 30.
Unbooked case, yeah.
Really appreciate you have gone through the previous scans, especially first trimester. Such a small uterine anomaly can only be identified in the first part of the pregnancy. Secondly, wonderful literature review you have given. It is a wonderful thing. But now you tell the correlation with your movie. As expected, whenever Palaniappan is there, we expect a movie. You have shown the movie clippings now. The correlation.
Dance star. There was dance.
No, there is only one Aishwarya Rai in that movie, but it looked like two. That's what it is.
Thank you for making me part of this panel. It was wonderful, sir. It was wonderful. Explanations and everything.
In these patients who are having uterine anomalies, so there are more chances of having dysfunctional labor in these patients. Is there any study?
Yeah, there are. Dysfunctional labor is a complication of this.
कब से हो रहा है ये अभी 2-2.5 महीने
I think we are overshot the time.
We are just about on time. It's fine.
Clinic is going on.
How much?
Dr. Sarita? Okay, Dr. Sarita. Dr. Parag?
Nice talking to sir. Sir, can I request you to leave?
Dr. Palani?
Yeah.
Dr. Palani, can I share one quick case? I had one patient primary breach and she went into preterm labor and I did a cesarean section, and as a routine, when I was examining the uterus, because that has to be a thing, you look for any anomaly, any septum. So I found that this was a unicornate uterus on the left side and there was a small rudimentary horn on right side. This is very early. So in those days, I was very happy that I have diagnosed a small rudimentary horn and I did nothing about it. And she delivered, I mean, I did a cesarean section, baby was fine, mother was fine. This girl was in a hurry to get pregnant. So within a year, she got pregnant again. And this time when she came, surprising for me, she had twin pregnancy, one pregnancy in one horn and the other pregnancy in the other horn. And I was cursing myself that why didn't I take out the other horn? So I convinced them that I should do a laparotomy and take out the rudimentary horn, because I knew now that the right side is a rudimentary horn. They took time. They said, okay, we'll come back after a week. I was scared that they'd run away. They came back after 1 week. Good for me. that the pregnancy in the right rudimentary horn had, become a missed abortion. So I heaved a sigh of relief. And then this pregnancy went on in the same horn, which had actually taken pregnancy to the term last time. And then second time I took out the rudimentary horn. So my personal learning is that if on cesarean section we find a rudimentary horn, we should not think it ke bichara sa hai, pada rehen do. It can cause havoc, even if it is non-communicating from uterine side, transperitoneal migration, and it can, take a pregnancy. So thank you, Dr. Palani. Beautiful two cases.
Thank you. Dr. Sarita has given us permission to end the talk with the ICOG team, Jignesh and Neelima here. So she said you could go ahead and end. And thank you very much, panelists. You were absolutely lovely. And all of you had your own rich experiences. And so you shared, and the discussion went on extremely well. And thank you very much, ICOG, Dr. Parag, Dr. Parul Kotadwala, and Dr. Sarita, and of course Malavika for doing the emceeing here, and of course all the panelists who did a wonderful job. And thank you very much. If there are no more questions, we will end the discussion here. And thank you very much.
Thank you, moderator. Thank you.
Thank you.
Thank you so much, sir. Thank you, everyone, all the panelists.
Thank you.
Thank you so much.
Thank you, sir. Thank you for
And
the
madam, you would be model in next generation, okay? Next.
Yes. I am.
Yeah, for that, I don't want to be born again, but if I am born, only OB-GYN.
Oh, great. You are dashing, madam. You will become. Thank you.
Okay.